femur bone.
No, scapula.
Thanks. Scapula. They're getting together. Why you are looking for extra mark? Don't do that. Change his side. Okay. So scapula. How many type of fracture does we have in the scapula? At least 5. Different type of classification. Do you remember? Type of classification sometimes based on the location of the fracture. Location of the fracture. What is the name? Glenoid fracture. Infraglenoid fracture. You have the slide. You can see the slide on there. So that doesn't help to me to remove it. Or supraglenoid fracture, or acromion, or clavicular. Okay. And the body, scapular neck fracture. We are talking about a scapula.
Yes, I know. The clavicle just three.
Most of them in the middle of the clavicle. I don't want to actually bring it to your mind. Actually, it's a kind of a specific, very distinct classification. No need to take it. You must get the whole of the concept. And if it's important, I will let you know to learn it much distinctly. Okay, the scapular neck fracture, the scapular body fractures, everything. So we can check it in a better slide. You can see it right now. Oh God, what is that? Hura went for work. What is happening? How many processes does we have? How many processes does we have? No, I'm talking about the neck and head of the scapula. How many processes? You do have two processes. At the superior part of the scapula, there is 1, there is 2. Do you remember the name?
Yes.
Yes, what?
The name of process. Spine process.
Right, menvar kalop. Kalop? I'm not sure in Arabic. Kalop. Crab. The black bird. Crab. In English we call it crab. So this is menvar kalop. So what is menvar in Latin? Coracoid process. You pass all of this anatomy. I must talk with Dr. Mojaber. How did you move further? How did you pass it? Okay. Are you agree? Chances? Are you agree? No. Coracoid process. And the other one? Acromion process. Acromion provide a kind of wider space for you, because I was bringing actually the upper extremity of molars. Forget it, sorry. When you have a kind of glenoid fossa, and you have head of the, what is the name? Humerus? Okay. So there's attachment 1/3. 1/3 of humerus will be attached with glenoid fossa. In hip, it's about 70-75 degrees. Here is 1/3. Why? Because you need movement. Here you need a stability. I mean the acetabulum and head of the femur. Okay, you need stability much stronger. This way. Much stronger in the ankle is in this way. Okay, but here you need movement. So the crockery process helps the bigger actually area for the head of the humerus, so that you can have a little loosey stability at the upper extremity. Okay, little wider area for movement. Good. This is the infraglenoid structure or fracture. This is neck fractures. This is the body fractures, and it's a longitudinal fracture or something like that. Yes? Okay, so how can we fix it? Which type of bone is scapula? Which type of bone? Long bone? Yes.
No.
Short bone?
No.
No bone?
Irregular?
Irregular. Yes, it's irregular. Or it's better to say that, what is type of bone in a skull? Flat. Flat bone. Or sacrum. Flat bone. So they are like actually alphabet for you as a physio. Type of the bone, type of the joint, origin, insertion, muscle, function, they are your regular actually basis practice. You must know that. No need to think about that or refer to a book, not at all. They are regular daily basis work. So that was the reason. Please don't lose your information at the side and go move next stage. No. And I'm asking you what type of the bone healing we do have. You must not watch yourself or the other person. You must say easily two types. With a cartilage actually mediation or without that. That's it. Easy. Easy. Okay, there's a flat bone. Look at that. What is happening here? Clavicle. How many screw on that? 1, 2, 3, 4, 5, 6, 7, 8, 9. Risk of fracture too much. Is it possible to make it lower? Probably. I'm not certain. Probably, yes. Okay, it's better to keep it much wider. Okay, this is type of the fixation for the scapula. Not very clear, probably in a screen, probably you see better picture, probably, I'm not sure. In any case, but when you have a look on this picture, you have a kind of different type of the fixation. You're trying to provide different kind of fixation and make it as stable as much as possible. I'm talking about the scapula, okay? Most of them are intermedullary nail, right? Yeah. Intermedullary nail. Ura. Nail. Tabarak. Right, tabarak.
فاطمة
Forget.
فاطمة
Fatma.
هو شنو السؤال؟
What is the type of fixation? What is type of fixation?
البيوترز
Where are you going, Tabarak? Tabarak? Vitaj, where are you going? Answer the question. Go. It's plate. It's plate.
Yes.
It's simple plate. Okay. They use the plate, different type of the plate. Probably what shows the hole? What shows the hole? The hole. What is that? The hole? DCP, dynamic compression plate. Okay. So it shows a kind of a sliding, perforating, a sliding. So it shows, compared to the normal plate, it's much safer. Don't move at all. Okay. So based on the situation, you can use simply some oil to protect, to attach different parts of the scapula. It's done. And so you have a clavicle injury, you have a you have an upper end of upper extremity injury or fracture. Is it different with the, for instance, upper end of humerus? Not too much in our case. There are different types of the fracture for the humerus, upper end. Okay. So when you are talking about upper end, easily is the 1/3 of the upper extremity, humerus. And very simple. You know how to look? The sharpness, you can see easily. The sharpness of stump. You know the remaining parts of the fracture, we call it stump. You know? Please remind it always. There are two stump here. It's part of the fracture. And the sharpness shows that there is a new fracture. And what is happening for the healing? It's bleeding, decreasing concentration of oxygen, monocyte, hemodynamic monocyte come to the area, get together, caving periods, osteoclasts. Do you remember? Okay. Removing the parcel and round the sharpness. Make it round. Remove the sharpness because you need a kind of smooth area to bring it to ducted and let it to provide a kind of bridge. Clear? Do you remember? Right. Okay, good. So there are different aspects of the fractures for the upper end humerus. Okay, we talk about the scapula. Right now you can see the humerus. And there's a surgical neck. This is the body of humerus. What about the other parts? Head of the humerus, lesser tuberosity, greater tuberosity. Okay, we do have all of them. How much of these concepts are inside of joint? How much of that are inside of joint? Are they in the joint? They are the insertion of some of the tendon, insertion of tendon, some of the tendons. For instance, the greater tuberosity is insertion of, that was the reason I told you, you must know every type of the muscle, bone, in a regular basis. Insertion of L3. You do remember L3? Okay. What about lesser tuberosity, Dr. Rahimi? Internal actually rotation. External rotation, internal. What is the attachment of internal rotation? It's here, something here. When you get a kind of AP, anterior posterior X-ray, lesser tuberosity is approximately back. What is the main source of the internal rotator? No. Good, but no. Coracobrachialis is something like abductor. There are some muscles named sternocleidomastoid, right? Some muscle we do have here was very famous.
Deltoid.
Rotator cuff. Do you remember rotator cuff? There are 4 rotator cuffs. 3 of them were external rotator. Just one of them was internal rotator. And what was the name of internal rotator? Sternocleidomastoid. We are stocking in sternocleidomastoid. Name of the rotator cuffs.
Supraspinatus, infraspinatus, deltoid,
Deltoid is not rotator cuff.
infraspinatus.
Tres minor and subscapular. Which one is internal rotator? Subscapular. You are stocking on deltoid. I'm stocking on sternocleidomastoid. You're stocking on deltoid. Deltoid is pure abductor and somehow external rotator. Okay, it's attachment of the scapularis. And also there is some attachment, you know. Sometimes you have an extra tension in the muscle. You do remember in orthopedic disorder, extra tension in muscle leads a kind of fracture. We call it a volusion fracture. Do you remember? A very powerful tendon. Get it, take it out, part of the bone, take it out. A volusion fracture, like chronostasis. A volusion fracture in lesser tuberosity. A volusion fracture, take it out. In greater tuberosity, for instance, deltoid. Okay, it's if the muscle very powerful.
Like dislocation?
Dislocate, not dislocate, detach. Dislocate means actually. Dislocate means actually bringing kind of the dislocation, subluxation in the joint. Detach is a kind of fracture. Part the guts, part of the bone. Part of the bone. Detach part of this bone. Good. So you have a kind of different type of the fractures, and all of them refers to upper end of the humerus, and they are all get together just one classification for you: the scapula fracture and the upper end of humerus. All of them are similar in terms of the physio treatment approach. Okay, so the humerus fractures, different type of humerus fractures. There is just one part of fracture, one fracture, two parts. That means there is no detach. There is no